Thank you for your kind remarks and welcome to the session on SGLTs and their role in patients with type 1 diabetes. So first of all, why do we need SGLTs in people with type 1 diabetes? Because there is a need, there is an unmet need. Majority of the patients are not able to reach target A1Cs and most people are getting overweight or obese, and thus we need some drug that will work. Unfortunately, all other drugs, classic for type 2 diabetes, like metformin or GLP analogs, they have not really worked well for type 1 diabetes as an adjunctive therapy. And thus, now we are looking at options of SGLT1 and 2 inhibitors. And I come back to that, SGLT1 and 2 inhibitor, sotagliflozin has got dual action. Majority of the action is the traditional like DAPA, which I'm sure Dr. Dandona will be talking on in this session, and same like EMPA, but also has a small effect on the gut, which is SGLT1 effect. In tandem 1 and 2 trials were identical in design, except one was done in North America, which was in tandem 1, and in tandem 2 was done in Europe as well as in Israel. The studies, both of them included about 800 patients with type 1 diabetes. Traditional inclusion criteria, type 1 diabetes at least for 1 year, adult patients, not kids, and EGFR had to be above 45 ml, and A1C is at enrollment had to be between 7 to 11. The patients were randomized into 3 arms, either placebo or 200 milligrams a day sotagliflozin or 400 milligrams a day in the 3 arms. The primary endpoint was change in A1C at the end of 24 weeks. However, there was an extension phase, and I'll come back to that, which was another 28 weeks, at which point there were the similar endpoints as well as the secondary endpoints. The secondary endpoints which were looked at is the net clinical benefit, which we have defined it as number of people reaching A1Cs less than 7 without any hypoglycemia or any ketoacidosis. So when the patients were screened, they had a baseline, they had a screening A1C, and then there was an insulin optimization phase, which lasted for 6 weeks. And at the end of the 6 weeks, in all 3 groups, as you can see, there was a drop in A1C of about 0.6%, equal in 3 arms, and at that point, the patients were randomized. In contrast to studies on EASD as well as DEPICT trials, nobody was excluded based on their A1Cs. At the time of randomizations, if their A1Cs were less than 7.5, they were excluded in the other trials, not in this, or if their A1Cs dropped by more than 0.5. Here everybody was continued. And it's also important to keep in mind that all insulin dose adjustment were based on insulin dose monitoring adjudicated, the committee. And clearly, because we don't have time, it shows that there was a significant improvement in A1Cs after the randomization, and dose dependent, slightly better drop in A1C with 400 milligrams a day as compared to 200 milligrams. Since they were double-blind trials, in the first 24 weeks, even A1Cs were double-blinded from the investigators. In the second extension phase, A1Cs were made available to the investigators, and thus you will see slight improvement because investigators were now allowed to adjust their insulin therapy as needed. As you would expect with all the SGLT2 inhibitors, there is loss of glucose in the urines and thus calories, and clearly shows there is a weight loss in the first 24 weeks, which continues up to 52 weeks in the double-blind way, up to 3 to 4% of the weight loss. Remember I mentioned earlier net clinical benefit. Net clinical benefit again was defined as less than 7% number of patients without ketoacidosis or hypoglycemia. Clearly there was 1.5 to 2-fold increase in all in tandem 1, 2, and 3 clinical trials. As has been seen with most other drugs, there was a change in insulin dose, but majority of the change in insulin dose in tandem 1 and 2 came from bolus insulin change, not the basal insulin dose. So clearly, because we don't have time and one needs to keep in mind the side effects, usual side effects are genital mycotic infections, diarrhea because of the SGLT1 effect, but hardly any patients discontinued from them. And the other important side effect is severe hypoglycemia. When you improve A1C, you would expect people to actually increase the risk of hypoglycemia. In contrary to in tandem 1 and 2, there was a significant decrease in the risk of hypoglycemia. In fact, severe hypoglycemia was lower. And in almost all the studies on SGLTs have clearly shown higher risk of decay. So in nutshell, the study that in tandem 1 done in the US, multi-center double-blind trial, clearly shows that sotagliflozin improves the glucose control with a weight loss and improvement in systolic blood pressure. And the number of patients achieving target A1Cs without severe hypoglycemia and or decay were nearly 1.5 to 2-fold higher. Thank you.
Thank you very much.